Lefort 1 type maxillary osteotomy serves to surgically divide the maxilla into a free inferior component containing the dental arch. The mobilized segment is held in a new position with metal plates and screws. For this reason, the procedure is the basis for the orthodontic treatment of a variety of dentofacial skeletal deformities. We shall review 5 steps of the osteotomy procedure. A significant part of the osteotomy occurs behind the portion of the maxilla that the surgeon does not see, and thus it is completed by tactile sense, combined with the spatial knowledge of pertinent anatomy. A guarded septal osteotome is used to separate the nasal septum and vomer from the maxilla. Direct the osteotome downwards and posteriorly. Directing it upwards risks damage to the septal cartilage. An oscillating saw with a thin, flat blade is used to complete the horizontal maxillary osteotomy. The saw enters the nasal cavity with the blade pointed downwards for ease of insertion and to avoid tearing of the nasal mucosa. It is then rotated towards the lateral nasal wall. The cut begins from the lateral nasal wall through to the anterior maxillary wall and over to the posterior lateral maxillary wall. Let's take a look at it again from a superior aspect. The lateral nasal wall measures about 50 mm and the saw blade typically 25 mm. Take note that because of the depth of the lateral nasal wall, the serrated portion of the cutting blade cannot be visible at this point. As you section the lateral nasal wall from posterior to anterior, be sure that the handle in which the blade is connected to is visible and away from the nasal wall before commencing with the osteotomy of the anterior maxillary wall. Once the medial buttress is cut, the saw must be controlled tightly as it will rapidly section the thin anterior wall of the sinus until the lateral buttress is reached. Pterygomaxillary disjunction is completed with a curved osteotome. Its separation is not visualized directly. Following the topography of the skull, the osteotome is placed in a pterygomaxillary junction. The osteotome is positioned parallel to the occlusal plane and then directed inferiorly. It is important not to direct the osteotome superiorly as to avoid lacerating the maxillary artery and inadvertent fractures of the skull base. The descending palatine artery is the most vulnerable source of bleeding during the pterygomaxillary disjunction because of its location in the posterior wall of the maxillary sinus. A finger can be placed behind the maxillary tuberosity to verify the separation and avoid injuring the vessels within the pterygopalatine fossa. A small, thin osteotome is used to separate the lateral nasal wall and posterior maxillary wall. The osteotome is inserted through the anterior maxillary wall until it reaches the posterior wall of the maxillary sinus. Gentle tapping will fracture the medial and posterior wall of the sinus. By gently pushing the anterior aspect, the maxilla is downfractured. If there is any resistance, the osteotomy sites are revisited. Once the maxilla has been fully detached, the descending palatine artery is identified and any bleeding from this vessel is controlled. We hope that the CT-based animation has helped you in visualizing certain aspects of the Lefort 1 type maxillary osteotomy.